Prospective evaluation of bacteremia rates and infectious complications among patients undergoing single-operator choledochoscopy during ERCP. Introduction. Rates of bacteremia following endoscopic retrograde cholangiopancreatography, ERCP, range from 6.4% to 26.5%. Despite these relatively high rates of bacteremia, cholangitis and sepsis develop in only 0.5% to 3.0% of patients undergoing ERCP. Although in previous decades prophylactic antibiotics were routinely administered to all patients undergoing ERCP, expert opinion has gradually shifted away from this blanket approach. The American Society for Gastrointestinal Endoscopy, ASGE, guidelines on antibiotic prophylaxis prior to endoscopy recommend antibiotic administration prior to ERCP only for patients in whom incomplete biliary drainage is anticipated. No ASGE or other endoscopy society guidelines exist on the role of antibiotic prophylaxis prior to choledochoscopy. Choledochoscopy allows direct endoscopic visualization of the bile duct. Although carbon dioxide insufflation has been described during direct peroral choledochoscopy, water or normal saline are typically used to insufflate the biliary system during traditional choledochoscopy. This facilitates distension of the bile ducts and improves visualization by clearing contrast, mucus, sludge, pus, and stone debris. Fluid irrigation may potentially increase intrabiliary pressures and may therefore increase the risk of procedure-related bacteremia and cholangitis. Biliary turbulence related to irrigation and to choledochoscopic interventions such as electrohydraulic lithotripsy, EHL, may also potentially increase the risk of bacteremia and infectious adverse events. However, no prior studies have evaluated the frequency of bacteremia, cholangitis, or sepsis following choledochoscopy. The introduction of the single-operator choledocoscope in 2007, as well as dedicated choledocoscopy devices, resolved several technical and logistical hurdles that were associated with choledocoscopy using older choledocoscopy systems. The number of choledocoscopies performed at most tertiary endoscopy centers subsequently increased exponentially. This marked increase in the volume of choledocoscopic procedures performed today makes the issue of choledocoscopy-related bacteremia and associated infection rates important. However, choledocoscopy-related bacteremia and infectious adverse events have not previously been carefully evaluated in a prospective manner. The primary objective of the current study, therefore, was to prospectively evaluate the frequency of bacteremia after ERCP and choledocoscopy using the single-operator choledocoscopy system. The study also evaluated the frequency of cholangitis and other infectious adverse events following SOC, despite the routine administration of a prophylactic single dose of antibiotic after the procedure. Background and study aim. Choledocoscopy is increasingly performed during endoscopic retrograde cholangiopancreatography, ERCP, for direct bile duct visualization. Choledocoscopy necessitates irrigation of the bile duct with water or saline, which may increase intrabiliary pressure and consequently the risks of bacteremia and cholangitis. The aim of this study was to prospectively evaluate the risk of bacteremia and infectious complications in patients undergoing single-operator choledocoscopy, SOC. Patients and methods. Patients requiring ERCP with SOC at 2 tertiary care centers were enrolled prospectively. Blood cultures were obtained immediately before the ERCP, after completion of the ERCP portion of the procedure to determine ERCP-related bacteremia, and 15 minutes after completion of SOC. Results. A total of 72 patients, mean age 64 years, 51.4% male, underwent ERCP with SOC. True positive blood cultures were noted in 20 patients, of whom 6 patients had transient bacteremia following ERCP. Of 14 patients with sustained bacteremia following ERCP or SOC, 10 patients had sustained bacteremia related to SOC. Despite the use of post-procedure intravenous antibiotic administration, 7 patients required further antibiotic treatment for infectious complications, 3 of whom were hospitalized in order to receive intravenous antibiotic therapy. Conclusion. the bacteremia associated with ERCP with SOC, and the subsequent risk of hospitalization for infectious complications suggest that pre-procedure antibiotic prophylaxis should be considered for patients undergoing SOC, particularly in older patients and those with prior stent placement or undergoing intraductal stone lithotripsy.